Welcome, everyone. Welcome to our special edition, our afternoon edition of our PCN pain rounds. Usually these are done in the evenings, but we have our special guest, Dr. Lalkhen, all the way from England. And so we really appreciate having him. Just a quick story. We didn't think we were going to get him. My name is Syed Quadri, by the way. I'm a family doc in Alberta and Airdrie, and part of the planning committee, the chronic pain PCN rounds planning committee. And I heard Dr. Lalkhen speak on the CBC Current, and this was last summer. And this was a few days before our planning rounds. And I was like, oh, this is a great speaker, but we're never going to get him. You know, he's written this book and he's international. We're never going to get him. But I mentioned him to our own guru, our own pain doc, and Dr. Montgomery. And she knew Dr. Chris Vanswick, which was the pioneer at the university, Salzburg Royal University Hospital, that that trained Dr. Montgomery. So that connection gave us Dr. Lalkhen here. So really, really happy to have him here. Just before we begin, we'll do some admin stuff. And before that, we want to acknowledge and honor the fact that those of us who are participating in the event across the province share the traditional and current lands of the many First Nations, Métis, and Inuit peoples. The province of Alberta includes territories in the treaties 4, 6, 7, 8, and 10, which include a diverse array of culturally distinct Indigenous peoples whose histories, language, and cultures continue to enhance our communities and remind us of our ongoing relationships with each other, the land, and our own process of reconciliation. The only disclosure we have is that the Alberta College of Family Physicians helps us with the infrastructure. So thanks to them for doing that for us. This is our wonderful planning committee. Christelle there will be managing and moderating the questions for us. Thank you very much for that. And we meet once a month to help organize these rounds. So this is again for primary care teams. We do it 6 times a year, and usually in the evenings, but special afternoon session today with Dr. Lalkhen. So please do provide feedback. We actually read every single comment and we use it for future topics. So please, there'll be a little link in the session near the end there as well. You'll get an evaluation at the end of the in about a week. Just for logistics, the chat box, just please use for our staff if there's any technical or logistical issues, but there's a Q&A function at in the Zoom function. Click on that for questions so that we can upvote them and so on, and Christelle can view them there and it'll be easy to manage. And just to get ready for the other rounds coming up, the next one will be May 17th. Dr. Smilich was part of our planning committee. He's all the way in New Zealand. He worked in Banff before, so we'll have international there as well. And then we'll be doing a PCN pain type of topic July 20th. We're just going to launch a poll. We want to see who's out there in the World Wide Web, who's with us today. And we'll start with the discipline. Agatha, we could just launch that poll there. And I'll just leave it on for a bit here. All right, so good range here. We have family doctors, NPs, pharmacists, physiotherapists, psychologists. So it's a good range there. Okay, and then we'll just get the next poll up here. This just gives us an idea of where you're coming from in terms of location, PCN, other location. Let's see. Okay, yeah, so good range. A lot from the Foothills PCN there, but lots representative from each of the PCNs. That's wonderful. Okay, great. All right. Let me just see here. So perfect. All right. So without further ado, I just wanted to introduce Dr. Lalkhen. So he graduated from the University of Cape Town in 1988 and started out with a 1-year internship in trauma and emergency center in South Africa. And so did that for about a year and then decided to change directions and moved all the way to England from South Africa. And he pursued critical care medicine and anesthesia. And he did a 2-year rotation in anesthetics in the southwest of England, in Bath and Swindon, and did further specialty training in Manchester. And then another switch from there and was looking at general practice, but fate intervened and pain medicine was on his next rotation. And so then the rest is history. And now he consults for the last 14 years, spending his time assessing and managing patients with chronic pain, along with psychologists and physiotherapists to help reduce the distress and disability associated with chronic pain. He also works 1 day a week in anesthesia doing various operations, including neurosurgical procedures, and also does electrical device implants for nerve pain. Along with that, very busy, teaches medical students and postgraduate physiotherapists, doctors, nurses at 3 universities in Manchester, and also has a medical legal practice as well. There'll be a detailed bio that we're going to include when we send off the slides. Also, we're going to put in the chat box here. Have a good read. It goes into details on Dr. Lalkhen's change in careers and why. So I do suggest you read that as well. All right, without further ado, Dr. Lalkhen, looking forward to hearing your talk. Thank you so much for joining us.
We were talking before we started the webinar that really the pandemic has brought people together and enabled us to really communicate with one another more effectively through these platforms. I've been asked to talk to you today, and I put this initial slide up because really chronic pain and working in pain medicine is very challenging, and often the inside of my head feels a bit like this. And I thought this is sort of a good graphic illustration of, how I like to think about things sometimes. So Laura's asked me, we talked about learning objectives, and she has read The Anatomy of Pain, which is a book I've written really to describe my practice and my understanding of pain medicine and the challenges that all of us face. And so the talk this evening for me is divided into 3 components. The first is really to try and explain pain to patients. The second is to try and outline, as far as I can see it, what we have to offer in the pain management landscape. And then the third really is to try and talk about where we're up to in terms of promoting chronic pain as a disease rather than merely a symptom. And I think that's a battle that's been going on for many decades now, started by John Bonica when IASP was founded in 1972. And, Chris Spanswick and Chris Main, who really founded the unit at Salford, were forerunners of an approach which really tried to, understand pain as much more than just a line-labeled pathway from periphery to brain, but really understanding the complexity of the experience and how it impacts on people, and then trying to translate that into a way of learning to live with pain. These are my disclosures. So I mainly have provided educational events for some of the companies who provide spinal cord stimulator implants, and I have received some travel grants to go to meetings such as the one in IASP. And the last time I was actually in Canada was at the Montreal meeting in 2010. And I think disclosures are important. They obviously do play a role in how people communicate unconsciously and consciously. And as Marcus Aurelius has said, everything we hear is an opinion, not a fact, and everything we see is a perspective, not the truth.
So I wrote this book, which the American editors wanted it called something different from the British publishers. In the UK, it's called Pain, the Science of the Feeling Brain, because really I wanted to emphasize that pain was an experience created by the brain. The Simon & Schuster wanted it called something else, and so they decided on an anatomy of pain. And then the paperback has now come out in the UK, and it's called Pain, What It Is, Why It Happens, and How to Cope. And there's also a Polish version and a version in Russia, and I think there's one in Chinese now. And really the book is very much, I would normally explain to patients about pain and how I would build up a picture about pain to individual patients. And it then goes on to really talk about the kinds of treatments that we have available, and also our news about the various issues in society, I think, which contribute to chronic pain, and how perhaps we can think of these issues long term. So as Dr. Kadri said, I'm from Cape Town originally. It's where I was born. It's where my family are from. And you can see it's a very beautiful place. And I was a bit missold on the weather in Salford and in Manchester. And when I got here, it was nothing than people said it would be. I'm an anesthesiologist by base specialty. So I ran away from home with the love of my life, who then went back to South Africa, but that's a webinar for a different day. And in the UK, really wanting to practice in critical care medicine. And I think that was very much because after spending a year in South Africa in trauma and emergency medicine, I kind of developed, I think, a bit of PTSD. And so I really wanted to deal with patients that were asleep and quiet and in situations that I could control. But eventually that wore off as I was absorbed into the medical system in the UK, and I missed talking to patients, and I missed helping or trying to help people understand what was going on with them. And also I missed going on that journey with people and trying to help them navigate, what is sometimes a lot of challenges in terms of their healthcare. And so I did think about becoming a general practitioner. My dad's a GP, retired only recently at the age of 75. And my brother is a GP. And so I did think about that, but then I happened to sit in a pain clinic and I thought, gosh, this is interesting. This is something I've never thought about. These are patients with significant challenges, and this is something that I might want to do. And so eventually I ended up working at Salford Royal, which is a big hospital in Manchester. It's one of the big teaching hospitals. It's a major trauma centre. It's a neurosciences centre. It's affiliated to the University of Manchester's medical school. And we have a large and well-developed pain service. In the UK, pain services historically have either consisted of an anesthesiologist with maybe a pain nurse, a physiotherapist if they were lucky. But we, as a consequence of the work done by people like Chris Spanswick, we're a large service in the sense that we have 5 or 6 psychologists, we have specialist nurses who run the inpatient pain service, so looking after patients with perioperative pain. We have medical consultants from an anesthesiology background, and recently we've trained a couple of GPs who come in and do clinics with us and support the pain management programs that we deliver, and really have given us a different perspective on managing chronic pain in the community. Because often we sit in our ivory tower, we have quite a lot of time with patients, but what our GPs have taught us is really how to deliver the message of chronic pain when we don't have a lot of time, and have kind of developed techniques of their own. And one of them is really worthwhile talking to when it comes to communicating the message of chronic pain to people rather than the knee-jerk reaction, which often happens in this country, which is to escalate medication. So we have a large pain service, and I'm very fortunate to work within that pain service. I put this up not to teach anybody. I'm sure you're aware of this, but I think these sentences do resonate. It's a personal experience, pain. Pain and damage are not the same phenomenon. What somebody tells you about the pain should be respected. I think there is a tendency to bring a lot of our own mess and a lot of our own thinking and judgment to the patient's space. And we do it unconsciously all the time. And I think that it doesn't help us and it doesn't help the patient. And I think it is important to understand that there is a point at which pain progresses from being a biological alarm system to being the disease itself. And I put the dragon up there because dragons, much like pain, come from our very primitive fears. There was a time when we were not able to protect ourselves, and the dragon is really an amalgam of very primitive fears. It is a tree snake that flies, that breathes fire. And those were the, archetypal threats that we were often faced with when we were very early on in our development. So the first thing I'd like to cover very briefly is to talk about explaining pain, to translate the complexity of mind-body science into patient-friendly terms. To me, this is all I do. in the context of pain management, and we'll talk about it a bit later, the drugs don't work. We've used them ubiquitously for chronic pain. They end up giving people horrible side effects, and we've only become aware of the side effects very recently of these medications. We do not know enough about the neuroscience of pain. We don't know enough about pain mechanisms to have designed sensible drugs that do not have spillover effects. For a long time, we injected steroid and local anesthetic into various bits of people, but we know those techniques have their own issues. We can try and modulate the nervous system with electricity. But really, we don't actually have a great deal in terms of modifying pain, both acute and chronic. And there are a lot of the drugs, if you think about them, the drugs are old and they have, as you know, lots of side effects. And at best, you might get a 30 to 50% reduction in pain. But what we do have is you have an explanation. I have seen people in clinic when they come in really stressed, wound up, tense, anxious, fear avoidant, holding their backs. And when you unpack what chronic pain is, when you explain that the pain is because their alarm system is faulty, that it isn't working properly, that the pain is not due to ongoing damage, when you step by step take them from understanding the basics of the pain alarm system to understanding why they have pain, why they're experiencing what they do, you see this visible relaxation. You see this transformation that takes place, and all you've done is change their cognitive construct. And most of the time in the pain clinic, that's all I do these days. A lot of the injection therapies that we used to employ have been decommissioned. Much of the medication is no longer prescribable. Interventions are a very narrow part of what I do from a therapeutic point of view. And so my job in the pain center is to explain pain. And particularly where patients are referred from our psychologists and physiotherapists because they become stuck, they have beliefs that their pain is due to ongoing damage. My job as a doctor, because, unfortunately, doctors are still seen as being authoritative figures within the medical hierarchy. My job is to explain pain to patients. And so what I'm going to try and do very briefly is just give you some, insights, some examples of how I've gone about doing it and what works for me, and which may help you within your practice. So, in the words of The Sound of Music, let's start at the very beginning. And I think what I would say is that what you really need to know is how pain works yourself. And in when you practice in pain medicine, as far as I can tell, you really need to have a very, very deep understanding of the biological alarm system. You need to understand that pain is a primitive alarm and that its purpose, the purpose of that unpleasant experience, is to alert you when something has gone wrong. And the example I usually give to patients is that if you stand on a drawing pin, and I will often during a clinic appointment, I will stand there and draw a picture on a whiteboard for the patient, and I will show the pathway from the foot to the brain with the various components. And that initial component is really important because there you can explain how anti-inflammatory works. So you can talk about transduction and nociceptors, and then you can talk about transmission to the spinal cord and what happens there at the gate. You can talk about perception and how the brain interprets the damage. And so I'll say, well, if you're walking around on a Sunday afternoon in your garden and you step on a drawing pin, then, it's perhaps not a big deal. You pull the drawing pin out. But if you were about to run the 100 meters in the Olympics, that's a very different injury. And therefore the pain is very different. So you start to move the patient from understanding that pain is just this simple system to understanding the complexity of pain, which then allows you really to talk about treatments and how, for example, psychological treatments may work in altering perception, and how the drugs might work and what their strengths and limitations are. But it really does start with an understanding of this model, which you have to effectively communicate to the patient. To me, this is the fundamental of pain medicine. And if we don't get this bit right, none of the other stuff we do makes sense. The drugs don't make sense. The expectations of pain relief don't make sense. The role of physiotherapy and psychology in pain management doesn't make sense. And so I can't really emphasize more how important this is. And I often use the example of David Beckham, who was injured in this football match. So he ruptured his Achilles. And what you initially see is he identifies that there's a problem at his Achilles. And at that point, transduction has occurred. So the conversion of a mechanical stimulus into an electrical stimulus. But, you wouldn't say he's in pain. He's perhaps mildly concerned. And then the electrical signal is transmitted to his brain. And then when that information is interpreted, you then see the distress and you see what we would generally identify as pain. And because David Beckham is a footballer, and patients often get crossed because I talk about footballers having very slow neurology, you see this step by step because there is a delay. And then only when he understands the context and the meaning of that injury do you see the pain being expressed. And I think this example really allows you to communicate effectively to patients the nature of pain as an experience. And then you see him, the Achilles hasn't healed, it's still broken, but he isn't behaving as he did in that initial picture because now the brain is making sense of what has happened to him. And understanding that pain can be modulated at the level of the brain and spinal cord is really important for patients to understand, particularly those with chronic pain, but even those who are undergoing an operation in the perioperative setting, because understanding that patients have the ability to choose how they respond to the unpleasant sensations coming from a particular body part is really important in their rehabilitation and managing their expectations. And so I think translating the science into a map that the patient can understand is fundamental to improving the way that we manage pain generally. And then ultimately understanding that suffering is a completely different component and a really separate part of the way that pain is perceived and interpreted. I think the other thing that I try very much to do is to communicate to patients that when you develop chronic pain, so that is pain that doesn't go away, that is a very different phenomenon from pain due to a drawing pin in your foot or a ruptured Achilles. And it is important to understand that even though the word pain is used, it is no longer a symptom. Pain is the disease. And I think that is quite important to separate the two, because if you then don't do that, then the patient expects their chronic pain to be treated in the same way as their acute pain. Their perception is it will be self-limiting, and their perception is that, you must have something that will make it go away. I think this is a really important paper, which I keep a series of scientific papers on my desktop. We live in an information age, and actually what I've seen in the last couple of years is people are quite skeptical about information and doctors. And so I tend to present information to patients in the same way that I'm presenting it to you. I try to translate the science for them, and I give them the opportunity to evaluate and read these papers themselves, and obviously help them where they can't. But I think the more you do that, it gives individuals who suffer with chronic pain agency. It allows them to take control, which is really what we're trying to achieve. And so this, I think, is quite an important paper for everybody to read, really. From a chronic pain point of view, I think one of the things we don't do very well in pain medicine is to produce formulations of pain. And I think the new ICD-11 classification of chronic pain is really important. I don't think we drill down enough into the mechanistic descriptors of pain to decide whether pain is neuropathic or nociplastic or nociceptive. And I think the more accurate and the more rigorous we are in this regard, the more effectively we communicate with patients, because the patient can then see that what you're doing is trying to formulate and understand their problem in much the same way that a diabetologist wouldn't just say you've got diabetes. They would say, look, you've got insulin dependent or insulin resistant or brittle diabetes. This is the treatment plan. Because it stems from that key formulation of chronic pain. And I talk about the components as highlighted in ICD-11 of severity, pain-related distress, interference. And I acknowledge and measure and communicate to the patients those cognitive and emotional constructs that are informing the pain experience and how that works from a neurobiological point of view, and also to look at what their strategies are in terms of avoidance and how social relationships impact on them. Unless you have a really powerful handle on these constructs yourself, patients will sense that you don't quite understand it, and therefore, well, why should they? And the deeper that I understand these constructs, the easier it is to communicate them to patients. And what you can also then start to do is to use the individual patient experience to communicate the message of chronic pain. So, for example, if you have somebody who's a software engineer, you can use computer terms in order to communicate what pain is and what chronic pain is, using that individual's experience of what they know. But you can only really do that if you understand what pain is. And I make the point to patients that really chronic pain is dysfunction of the nervous system, and that we do not as yet have routinely available techniques to see the nerves and how they're not working properly. But then I remind the patients that, in the same way there was a time when we didn't have CT scans and we used to accuse people of all sorts. One of the things that I think we're often hampered with is this issue of imaging. And so the paper on the left, I routinely show to patients where, changes on an MR scan in asymptomatic individuals. I show them that, look, there isn't a correlation between changes on a scan and what you're experiencing, because where the patient perceives that their problem is due to changes on a scan, they will expect a biomedical solution. And I think it is important to introduce the patient to the complexity of chronic pain. And that really is a route into understanding the biopsychosocial model of chronic pain and to formulate what is the biology. Is it nociplastic? Is it nociceptive? What is your immune system doing? What's the role of obesity? I talk to patients a lot these days about the fact that obesity results in inflammation. Most people think they've got back pain because they just do it. But once they understand that adiposity contributes to inflammation, which affects their hypothalamus and their pituitary, which then, affects the stress response, which then affects their pain response, it all starts to make a bit more sense. Rather than patients feeling judged or marginalized, they start to become owners of their own treatment. And rather than going to a reductionist biomedical diagnosis and just then providing an individual with a treatment which doesn't help, and they then have iatrogenic distress, and they then come back, disappointed in you, and so starts this vortex of disability. And so there are quite a lot of slides, and I won't go through all of them, but really all of those slides are ones that I would use in a clinic setting to demonstrate to the patients what the foundation is for understanding pain. And so neuronal plasticity is really important. So how does chronic pain develop? So I say to somebody, for example, acute pain is when someone breaks into your car and the alarm is triggered. So the alarm is the pain. That's normal. But then you fix the car. But since that break-in, now the alarm just goes off all the time. So the problem, even though no one is breaking into the car, so the problem there is not with the structure of the car, the problem is with the alarm. And often you get this sort of initial skepticism and then a sort of slow realization and understanding of what you're trying to say. And I show people how the peripheral nociceptors change and how the spinal cord changes and why they're experiencing pain even though there isn't any damage. So this idea of nerves jumping onto other nerves and light touch causing pain is often quite powerful in demonstrating from a clinical point of view, so allodynia or hyperalgesia, and then demonstrating the basis from a pathoanatomical point of view and a neurophysiological point of view of why they're experiencing hyperalgesia and allodynia. And I talk about the fact that there are brain changes. This can be quite scary. So often, once I did this, and then the patient was like, oh, well, I'm becoming demented. And so you have to be careful with this information. But the aim is really to understand that chronic pain is not in your head. It's not made up, that there is a biological basis to chronic pain. And if you can communicate that effectively to patients, you can start them on their journey of living well despite persistent pain. I tend to be quite fastidious about what kind of pain they have, because I think that does lead you down different pathways. And I will show them how I'm trying to arrive at the diagnosis. And if I'm not sure, I'll say, look, I'm not sure. And this is the pathway that we're going to go down. So really, that is just, I think, the fundamentals of what we do. And it's really what I tried to do when I wrote the book, is I tried to unpack for the layperson how pain works, because I think there is a lot of misunderstanding about the complexity of pain, not just amongst non-healthcare professionals, but often amongst healthcare professionals. There are doctors who are very much focused on structure, and therefore, if the knee looks this way and it's replaced, you'll be fine. And then they cannot understand why the patient is not fine. They disconnect the knee from the back pain and the anxiety and the depression and the catastrophizing and the social situation that knee finds itself in and the family that it's situated in. And often this leads to poor health outcomes. And so really, I think as clinicians practicing in pain medicine, we have a real responsibility to communicate effectively with the patients we treat, to try and explain the complexity of pain to our colleagues who are not working in pain medicine, and then to promote an understanding of pain as an experience to the wider society. And actually, if you take nothing else away from the talk today, then really that would be my key message, is explaining pain in a sensitive and kind way as you can, is a way of accessing and reducing the stress response that people feel as a consequence of pain, both in the acute and the chronic setting, managing expectations, understanding the limitations of what we do, I think is fundamentally important. So the next section really is just, so this is a breakdown really of how I look at pain management. And I'm not saying that my view is perfect or that it's a correct view. It is just how I think about delivering care whenever I'm in a clinical setting, either acute or chronic. In terms of managing acute pain, obviously, you want to remove the mechanical, chemical, or thermal nociception. That's the sort of basis. You also need to manage expectations. So I often say to patients prior to an anesthetic and an operation, I say, listen, if naught is no pain and 10 is the worst pain, I can do 4. I can maybe do 4 to 6 out of 10, but I can't extinguish your pain completely. You're consenting to this damage. This damage will produce unpleasant sensations, but if you feel uncomfortable when you wake up, it isn't because anything's gone wrong. I sometimes say to medical students, if you're going to propose to your partner, you need to manage expectations. So say I can, buy a 1/4 carat D-class diamond with 2 inclusions. That's what I can afford. If you then come along with a 1/2 carat flawless diamond, you're a rock star. But if you leave things open-ended and you return, then, the expectation might have been a 1 carat diamond. So I think managing patient expectations and understanding or communicating to patients really that what perioperative pain management is about getting them going and preventing complications from not moving early enough. And so I think we could do a lot from a prehabilitation point of view to improve outcomes in terms of acute pain management simply by reassuring and managing expectations, because what we've done in the past is just chuck loads of opioids at people. And there are vulnerable people who are susceptible to developing problems when exposed to opioids. As we well know, I don't think we've been fastidious enough in working collaboratively, anesthesiologists, surgeons, physiotherapists, occupational therapists on the ward to help that patient along their individual pathway in terms of the perioperative setting. And I like to look at things in this way, using that same model that I showed you earlier in terms of thinking about how I can influence the perioperative course. In terms of chronic pain management, the aim really is to reduce the distress and disability and improve function despite persistent pain, because we can't cure chronic pain. Have a role, interventional pain medicine techniques have a role, and psychology and physiotherapy techniques have a role. And so the three interact with one another to produce, ideally, a patient who can live well and adaptively despite persistent pain. What do we mainly treat? Chronic widespread pain, fibromyalgia, low back pain. That's the biggest bit of our work. And then osteoarthritis and spondylosis, neuropathic pain, chronic post-surgical pain. But really, fibromyalgia and low back pain, that's really the majority of what we offer. So the red is what we probably can't offer anymore. The green is what we're commissioned for, the dark green, and the light green, we can still offer, but the problem in pain medicine is evidence. We're not great at collecting evidence. A lot of what we do is not standardized. We don't work collaboratively. And as a consequence, it's very easy for commissioners to come in and go, well, I'm not funding. Sometimes the work you used to beat us with. So it is a difficult space to work in. We are constantly under threat in terms of the treatments we are able to offer. Really, in my view, nobody has, in terms of pain management as a general principle, everybody has something to contribute: psychology, physiotherapy, occupational therapy, work experts, doctors. And what we help people is when we work together. When we stay in our silos, when we protect our individual patches and our individual funding, ultimately, we all fail. If one of us fails, we all fail. If one of us succeeds, we all succeed. So I think as a general principle, understanding what your psychologist does, understanding what your physiotherapist needs from you as a doctor is fundamental. Learning about psychology and learning about physiotherapy so that you can really explain to the patient, when I'm going to send you to the psychologist, not because I think you're mad, not because I think you're making things up, not because I think you're depressed, but because we know that these pathways from your brain to your spinal cord become less effective when your mood is low because your serotonin and your noradrenaline is low. And if you can change the way that you think and feel, you can increase those chemicals, which will make you feel better. The physiotherapist can teach you how to manage your activity so that you don't flare your pain up. This is what they might do, but I'm not an expert. I'll leave it to them. So what you get is this glorious symbiosis between clinicians in order to improve quality of life. The other thing is, we used to start from the simplest treatment and go to the most complex, but that isn't really effective. What you want is to evaluate every treatment in terms of its safety. Is it appropriate for that condition? Is it fiscally neutral? And is it efficacious? And that's what I would look at in terms of evaluating a treatment. So in terms of the drugs, I often show this to patients and show them where we try to modify the pain pathway, either in the acute setting or the chronic setting. But we know that the evidence for the treatments are within a narrow group of conditions, diabetic peripheral neuropathy. They've spilled over to be used in chronic pain generally. But we know that the numbers needed to treat are not great, and the numbers needed to harm are not as high as we'd like them to be. We also know that whilst the evidence might be robust in terms of the quality of the studies, the effect sizes are moderate. We know that there have been issues with gabapentin and pregabalin in terms of suicidality, in terms of accidents that people have. Car accidents have increased in people on gabapentin. And so whenever you use these medications, they need to be used with care. And the same is true, really, of the antidepressants, the SNRIs and the tricyclics. And I think it is important, that to understand that this is chronic therapy, and that I posed this to a group of non-medical prescribers the other day. Is the pain you're treating neuropathic? What are the patient's expectations? What are your aims and expectations? I often say to patients, look, the drug that I'm giving you may change the volume of the amount of activity within your nervous system, but if the brain that music reaches still hates the song, then it doesn't really matter how much you change the volume, you're still going to be really bothered by the song. So once I reduce the volume, that new level becomes a new loud. And so over time, it is important to evaluate that medication in terms of titrating it down and seeing whether it is actually having an effect in terms of improving the individual's function or not. I know you've had talks about opioids, so I won't really go through that, but these slides are included for your interest, really. And to raise the awareness, I'm sure you know about the fact that opioid administration chronically dysregulates reward and stress. And so really, it just turns chronic pain patients into zombies. And what it does to the brain is it stops the brain from actually being able to utilize those psychological techniques which are effective in the management of robbing people of the ability to process affectively and cognitively. So I think, they don't do anything. And often when people have been on high-dose opioids and you bring them down, they'll say to me, my pain's the same, but actually I feel so much clearer. And I think there is the risk potentially of us making the same mistake with cannabis by not evaluating which molecule works most effectively in which patients for how long. And I think these are cautionary tales. So I don't know if any of you know the verve, but it's on, the drugs don't work. So psychology and physiotherapy really comes from this paradigm shift and the attempt to address the predictors of pain and disability. We programs which aim to teach people adaptive pain management strategies, and the aim really is to reduce distress and disability. The problem is often of scalability, so how do you deliver the maximum techniques that are offered by physiotherapy and psychology, and how do you deliver pain neuroscience education at scale? And I know in Canada, people are often quite far apart. So during the pandemic, we've started doing online programs. And the reason I wrote the book really is because not everybody has access to a pain service like ours. And so, that patients can educate themselves to a degree about what is going on with them. And I think that is the problem with what we do in pain medicine sometimes, is that we have silos of or little areas of excellence, and I think Salford is one of those areas. But around the Salford area, in the rest of Manchester, there isn't really the equivalent of what we offer. And so it's just a case of fortunes of birth and postcode, which lead to access certain places. So there are interventional pain medicine. The way I think about it is destructive and non-destructive. And, increasingly we don't do very many interventions. Gone are the days when we did lumbar sympathetic blocks and lumbar facet joint injections. We'll do transforaminal epidural steroid injections where people have had nerve root compression in a very short period of time, but we rarely see the patients that soon. We do offer spinal cord stimulation, which essentially stimulates the spinal cord and resulting in the release of neurotransmitters, consequence of axonal depolarization. It's primarily there to treat neuropathic pain, and the aim really is to treat neuropathic pain, usually in the context of failed back surgery and CRPS. More recently, there is evidence for the use of spinal cord stimulation in painful diabetic neuropathy. And I think spinal cord stimulation is one of those treatments which is actually has a very good and robust evidence base, but which has very variable penetration, not just locally, but globally in terms of what is available. And yet, it is a non-opioid, non-pharmacological, highly effective treatment. And our unit has devised its own ideas around which patients do well, because much like I talked about the volume of the music with pharmacological agents, the same is true with spinal cord stimulation. You can reduce neuronal hyperexcitability, but if the whatever messaging gets through is interpreted in a catastrophic manner, then it won't lead to an improvement or a reduction in distress. And so you need to treat that brain first and how that brain deals with the messages before you really try and change the volume of that radio. There are different patterns of stimulation, and we have a complex pathway in order to make sure that we're spending the money that SCS costs in a helpful way. Ultimately, what you end up is with leads within the epidural space that can then modulate the spinal cord. And we have good outcomes. You can see there's a pain reduction of 8 down to 3. And each one of these is a patient. And what you can see is that there's significant reduction in pain, 50% being taken as success with the therapy, which results in people being able to reduce their medication, improve their sleep, and improve their function. Obviously, you have to communicate the adverse events to patients, and we do that as a part of our clinical. So just the last little section is, this is quite a big one, and all I've done is pick out some of my own thoughts about pain. I don't think the general population understands what chronic pain is. Most people, think they know pain. Pain is like love. Everybody knows what I love you means, but, it means different things to different people. I mean, I always define it for my wife. I always say to her, when I say I love you, it means that I'm willing to nurture your personal growth. It is important to understand or to try and unpack those common experiences that we think are well understood. And I think part of the societal stigma associated with chronic pain is because people just don't understand that it's a disease. Even where diseases are accepted, like diabetes or hypertension, there's a judgment. Lung cancer comes with a judgment if you're a smoker. And so I think trying to come up with some magical formulation, these are just some of my own thoughts that I sit with on a day-to-day basis in the clinic. And I think the new classification of chronic pain as a disease by ICD-11, if we all adopt this, if we all have a uniform global approach to the formulation of chronic pain as a disease, and if we start practicing in a collaborative and cohesive way, then we will begin to emerge as a specialty that other people take seriously. Whereas at the moment, I think certainly in the UK, pain doctors are very much seen as fringe division. And with the reduction in commissioning of various treatments, fewer and fewer anesthesiologists are choosing to undertake fellowships in pain medicine. And so I'm kind of a bit of a dodo, really, in terms of an anesthesiologist with an interest in pain. But my belief is that chronic pain management doesn't have a place in secondary care. It should really be firmly lodged with primary care physicians and physiotherapists, or psychologically informed physiotherapists, because that's where you can help the vast majority of patients. And the job of an anesthesiologist with an interest pain may be in neuromodulation and spinal cord stimulation. But I firmly believe that psychologically informed physiotherapy and primary is where the vast majority of pain management needs to take place. Besides that, trying to be specific and diagnostically robust in terms of what kind of chronic pain the individual has, and formulating that is fundamental. And also, collaborating is, I can't emphasize that enough, that none of us has the answer and we all need to work together. And ideally, this is what you want to see, but often this is the reality, is that we're all miles apart. Competition can be useful, but certainly we've seen in the last couple of years with this pandemic that the world is global. To cooperate, standardize training and services, make sure that we have robust workforce planning, collaboration, and really, I think we don't attend enough in society to musculoskeletal health. People are aware of their cardiovascular health, they're aware of their respiratory health, we talk to about diet and exercise, but, the actual vehicle that will carry you, until you die is not one that we maintain. And our lifestyles and the way we live in the West certainly is not set up for that. We understand, and there is information about what diet and exercise and which foods we should and shouldn't eat. But, I walk into my local supermarket and I think, gosh, there are about 3 aisles of food that I should purchase. But there's about 10 other aisles where I can purchase things that ultimately probably are not going to be particularly good for my musculoskeletal health. And I think that primary prevention is something that we really need to be much more about as a society if we want to promote wellness, rather than treating disease. That's my wife picking oranges, and the reason I put the slide up is because we were on holiday and we needed to get to this orchard, and there was this road. There was also this sign which clearly said go right, but I said, look, the orchard's there, let's go left. And we ended up on a mountain and needed to come down. And the point I make here is that I think being aware of your own biases is quite important. And I think being aware that, we think in particular ways, and those ways are often not helpful to patients or ourselves, and that we need robust evaluation of the evidence is something quite important. And our thinking can often be quite flawed. One of the things I would emphasize is this is a difficult arena to work in. It is emotionally exhausting to deal day in and day out and to help people with persistent pain, because pain as a social phenomenon is designed to elicit a response from the individual that pain is being communicated to. And it is important to monitor your internal environment as you're sat in clinic to ensure that you don't adopt one of these roles, where you rescue people by offering them therapies which won't work, where you judge people for the way they're presenting, or where, you offer a therapy, it doesn't work, and the patient then blames you. And so I think this can lead to burnout, and it can lead to a very unsatisfactory practice. And so it is something that I think we need to be aware of. And we had a tuck shop in the corner of the pain center coffee room, which eventually got banned. it led to what we called Texit, which was the tuck shop exit, because whenever somebody had a particularly difficult encounter, they would go to this cupboard and you kind of see them make a beeline for the carbs. And I think that can often happen if you don't process what's happened in the session you've been engaged with. And again, you know, chronic pain is complex and there will never be a simple solution. What I think ultimately we need to do is to evolve to redundancy, because I think pain management, anybody who works in healthcare should be an expert in pain management, because I think ultimately that is the only way that we really are going to succeed. So thank you very much for listening to me. I do apologize for the slide issue at the beginning. These are just, you know, some of the things I tell myself every day. If I'm in front of somebody, and including you this evening, all I'm trying to do is to be helpful, you know, to try and give you some of the insights into the practice that I try to promote on a day-to-day basis. And Kierkegaard wrote that all genuine helpfulness begins with humility before those we wish to serve. And therefore, helping is not a desire to dominate, it is a desire to serve. I think it is important to look after yourself, to be compassionate to yourself, to understand when you are being affected by the people that you are trying to help, and also to be aware of the evidence and to try and evaluate that evidence as early as possible. Patients have their own timetable for change. All that you can do is be to be a partner on that journey, but ultimately understand that whether the individual accepts what you have to offer in terms of pain management and implements those changes is on their timetable. I love this book called Think Again by Adam Grant. It's really well worth reading, but it certainly helped me just think about my practice and to not be narrow and just do the same thing over and over again. And ultimately, all that we can do really is to act in a manner that leads to the alleviation of unnecessary pain and suffering. So this is a cave painting from South Africa with two people on a journey together. And I think it often, when I saw it, it was very evocative of what I think being in a pain clinic and being a healthcare professional really is all about. Edward Trudeau was a neurologist, French neurologist, and secure, often to relieve, but always to comfort. And I think that, you know, we are privileged as healthcare professionals to be able to be there on journeys. And so I think it is a real privilege, and a privilege really to speak to you. So thank you for listening.
Oh, thank you, Abdul. It's Christelle. I'd love if you could show your sweet face to us and turn on your video for a few questions. And you're welcome to unshare or however you'd like to proceed.
Let me just, so I disconnected my webcam when I had my little meltdown. So if I see if I can back on and then get back to you. I have more in Kirk at the moment. So.
Sounds good. And you can leave your slide on if you'd like. Just the last one. That quote is so poignant. You're welcome to leave it as such if that's easiest, because that's by not our Prime Minister Trudeau, but by another Trudeau. But yeah, thank you, everyone. If you needed to finish finessing Dr. Lalkhen, that would be great. But we do have a few questions that I kind of was, that looks great. Thank you. We do have a few questions, and also I have a few questions myself. A lot of the aspects that you spoke about really resonated with me. You spoke about expectations, you talked about transformation, you talked about translating knowledge. So I'm going to start with an opportunity to reference that the International Association for the Study of Pain this year for 2022 is using the global year. Their global theme for the year is translating pain knowledge into practice. And I think this is what we were trying to espouse. And so when you talked about just starting the conversation and just beginning it, do you have any practical pearls regarding just to start that conversation that you've used that you found to be very transformational that you could share with the group that's still with us?
So the first thing, what I would often do is, I used to be a bit of a talker. I can't, my wife's a very quiet person, and I think I've learned to be a bit quieter because of her, but I often will let patients talk for the first 5 minutes of the consultation to unpack what they understand and then start from there. I think there is a tendency for us to come in with our agenda, but I find jumping off of what the patient understands about their pain is important, not to contradict them, but to try and sort of gently explore what underpins their understanding, who's told them what, why they believe what they do. And then once they've done that, what I'll say is, look, this is what I understand about pain. And these days I use we have a whiteboard with marker pens in the clinic, and I will draw a picture of a person. And patients are often quite rude about my artistic skills. One of them said, "Oh, it's very good that you went to medical school because you never." I'm like, seriously, I'm trying to help you, and you're insulting my artistic skills. And so then I draw the drawing pin in the foot, and I show them about inflammation and how that attaches to harm sensing receptors. And then, that message goes to the spinal cord, and it's the junction box there that is important. And then the message goes to the brain, and then the brain makes sense of it. And I give them context in terms of, if it happens on a day when you're not doing anything, then this might happen. But when it's important, then that message is amplified. Your brain has the ability to either increase or decrease the signals, and therefore, change the pain. And so I say to them, look, that's the normal biological pain alarm. That's how it usually works. And then I usually have to say, but in your case, the alarm has become dysfunctional. The alarm is no longer working as it was intended. And so it's on all the time. And I often say to people, look, living with this alarm going off all the time in your bodies. And I'll say, it's like living next to a neighbor of yours who has a broken house alarm. You'll go out a couple of times, and that's like having tests to check that nobody's breaking into the house. But then eventually you realize that actually it's the alarm that's faulty. But now you've got to learn to live with the sound of that alarm going off all the time. And then I'll say there'll be times when you're kind of happy and distracted and you're doing things you like and the alarm is still there, but it's not as intrusive. But then there are times when you're upset or angry about something else, or your children are being naughty. And then that alarm, which actually hasn't changed volume, seems louder, is more intrusive, and has a bigger impact on you. And I'll say our job is, well, we can try and reduce the volume of the alarm, but, we're not great at that. But what we can do is teach you how to learn to live without that alarm being intrusive. And, I don't have any empiric evidence for you to say that my approach is brilliant. And I do think that some people are at a place where they listen. And then there are times when people are just not accepting, and they continue to want to really access a volume control. What they really want is to reduce the volume of that alarm, and they're not interested in learning to live with it. And, all you can do is say, well, you're at that point in your journey. And this is the information about what we understand. And we will be here if and when you want to avail yourself of what we have to offer. And that's really all we can do, really. Yeah.
And absolutely, I think what really speaks to is language matters. It matters what's
Oh, yeah.
meaningful and what the person is ready to hear.
Yeah.
And that kind of segues me into another question that someone has asked about health literacy. So of course, when we're talking about metaphors, we're talking about stories, we're talking about relatable. If someone is into sports, football, literally
Yeah.
the Canadian or the European. So I'm wondering, the question was, what are your thoughts on good ways to determine a patient's health literacy, whether it be while you're having the consultation or the appointment or the meeting or beforehand? Do you have any thoughts regarding that?
Yeah, so we have a questionnaire we send out prior to the appointment. And that questionnaire has a series of psychometrics that measures anxiety, depression, it measures. But it also asks the patient, about the individual suffering with pain, about, when did your pain start? What have you seen? What are your thoughts about your pain? What do you want from the clinic? And an assessment of that document does give you insight into how engaged the person is, because if they don't return the questionnaire, well, that gives you some information. You can look at how well it's completed, how articulate they are. But I think ultimately, for me, certainly within any conversation, it's about listening. It's about really understanding that communication between people is impossibly ineffective. I was having a conversation with my sister the other day. My sister is really smart. She's a clinical psychologist who's doing a PhD on that I don't understand most. It's the phenomenology of the partner experience in Huntington's career. And we were having a conversation and there was a lot of misunderstanding, even though we're two people who communicate probably at a fairly high level. What she was communicating to me about a construct and what I understood about that construct was just not the same. And at one point I said, look, I don't actually understand what you mean, because I don't understand what that word means. And I think what I do a lot with patients is to check that I'm understood. The other thing is that a clinic consultation, I've realized, and the evidence is that people remember very little of what you say. Now, sometimes I think I'm an absolute rock star, and I've given this, Beethoven-like explanation to a patient. And then the psychologist comes back to me a few months later and goes, that patient really didn't understand anything you told them. I'm like, what? Really? So now what I do is I use the voice memo function on people's phones, and I record my feedback of the consultation, and I say to them, look, you're not going to remember everything I say, but go home and have a listen to this. And if it doesn't make sense, contact the service and I'll explain it to you again. But I think we need to use technology a lot more in terms of making that experience with us in clinic more permanent and more valuable. We also refer people to YouTube videos who perhaps don't or can't read. And so what I will offer patients is a range of learning opportunities with a variety of media, so that hopefully I'm not discriminating against anybody in terms of their ability to understand what is actually quite a complex message. The idea that pain does not mean harm is really, most orthopedic surgeons will just look at you as if you're from Mars when you them. And, in my medical legal practice, I'm having to explain that to barristers and to judges. But people hold fast onto this idea that pain is predictable, pain is always proportional to tissue damage, and that any pain where they can't demonstrate damage is made up or psychological.
That is very impactful. And I don't want to take away from a thought, because you might have paused for your thought. But
No. I ramble a bit, so I just yes.
No, I think, no, you're not rambling. You're actually providing extra fabulous nuggets that are helpful. And I think you hit the nail again on the head regarding listening and taking the time to give folks permission to express some of their concerns. When I feel pain, I feel like something is happening, something is wrong, I've damaged something. And it comes down to language. It also comes down to what are our expectations of you, as you mentioned, and their expectations. So maybe we could end with this last question or comment, and we're going to have to probably get you back again. But do you have any helpful thoughts about managing folks' expectations about a certain modality, whether it be medication or expectations about pain, how they were socialized, and even mitigating or attending to our expectations that we might have, not seeing our agenda, but moving with the patient? So that's a pretty big question. So I'll let you go with it however you'd like.
So there are a couple of things I would say to that. One is, so during the pandemic, we had a lot of time on our hands, and I started listening to podcasts and Audible books. So one thing I would just say in relation to the previous point is, if you want to train yourself to listen and pay attention and focus, try those, and then try and remember what you listen to. The other thing that I find helpful with patients is objective scientific foundational evidence. So I won't say this is what I think, or this is what I believe will happen. I'll say, look, this is the evidence. And I show them those papers about the pharmacological outcomes from neuropathic pain medication and the side effects. I draw a seesaw often for patients, and I go, look, ideally we'd like the benefits to be heavy and the risks to be light, but most of the time we end up somewhere halfway. I don't know if is a seesaw the same, the children's toy, a seesaw in Canada, the same as a seesaw, where one child sits on one end and the other child sits on the other, like balancing scales? Is that something is that called something different in Canada?
I think it's a little bit similar, but I think we can get the gist of it. So go for it.
Yeah, so basically that's what I'll say is that, most of these treatments are balance of benefit versus the side effects you might experience. But I think the key is to really show patients the evidence. And as I said, for example, with our spinal cord stimulator practice, we those slides I showed you about our outcomes is exactly what I show to patients. And so it's not me versus the patient. It's not me representing the medical industrial complex. It's me saying these are the strengths and these are the limitations of what we have to offer as we have studied it in scientific journals. Because I think that's one, it takes the stress away from you as somebody who has to deliver. And so it tells the patient that this doctor has bothered to show me how they've arrived at conclusions with regards to how this treatment may assist me.
Oh,
and I think wonderful. So I think at worst, it's, patient understands at least the limitations of your craft. And at best, what you've done is contracted with somebody in a candid, egalitarian fashion, respecting their autonomy and also freeing yourself from the burden of being a rescuer.
Oh, wow. Thank you. You brought that full circle. And I know a lot of us, it's 1 o'clock, at least in Calgary time, might be needing to attend to patients and going back about our days. But on behalf of the PCN Pain Rounds Planning Committee and all those in attendance, we want to thank you for joining us transatlantically, for sharing your passion, your obvious expertise, and just a new way forward. It would be pleasing to have you again. However, we know that your time is precious, so we'll talk about that in the future. So what you said about being compassionate, balancing the evidence, the narrative, and the that comes from listening to our patients is just so profound. So thank you so much. And I'd like to remind folks your feedback is most appreciative. So if you could provide us with your feedback with the emails that will be sent to you, that would be great. As well, our next event is May 17th with Dr. Christina, pardon me, Lilo and Dr. Dino Schmilitz about the patient medical home. And stay tuned for more information. And thank you for our partners with the Alberta College of Family Physicians. And look forward to seeing you soon. And thank you so much for everything, folks. And have a good rest of your afternoon.